It's tough to say, and I'll tell you why. Primarily because our diagnostic testing and the medicines and the interventions that we have now, be it catheter-based or surgical, have come such a distance since 30 years ago. So the tools that I have at my disposal now are different than the tools that were available 30 years ago. And because of the way medicine has come along and the way the world of congenital heart disease has come along, I think the risk assessment has changed. The management of those risks has changed. So even though these patients still had the same risks 30 years ago, what we can do now to mitigate that risk is much better than what people used to do maybe about 30 years ago. So a lot of this has to do with newer medications. The guidelines have changed. We all follow guidelines in cardiology, so there are guidelines that change every few years. What we do now, we wouldn't do maybe 30 years ago or 20 years ago. What I do now may not be done 20 years from now because there might be newer drugs, there might be newer interventions. These children, as I say, these young adults may have better opportunities 20 years from now. We are now developing valve and valve transcatheter techniques, so we're trying to move away from open heart surgery as much as we can. It's not openly available for a lot of congenital heart disease patients, but we do a lot of valve and valve patients, which means that we're trying to cut down on further surgical procedures. If you've already had 3 or 4 or so and so forth, the next 10 or 15 years, that is the wave that's going to come around. We now have subcutaneous ICDs, which means no leads go into the heart. We can just place it right underneath the chest. We didn't have that. So now you think about it, you have this young woman who has congenital heart disease, has multiple open heart procedures. You're not even touching the chest wall. You're just going underneath here, putting an ICD because that's the safest way to do it. You need a new valve. We can put a catheter through the groin. We put a new valve in the heart. Techniques that we didn't have 15 years ago, and God knows what's going to lie ahead, in the next 10 years. I think the surgical procedures and the catheter procedures are getting better and better. The surgeons, the ICU docs, the catheterization docs, they're all getting more and more sophisticated. The outcomes are getting better. Most of these children who were born with congenital heart disease survive. I mean, the survival rate, as I said, is you're higher than 95% of children with congenital heart disease who survive. In fact, if you look at all chronic illnesses, congenital heart disease is the one that survives the most. It survives the most. It beats childhood cancer, it beats cystic fibrosis. It is the one chronic condition that has beaten the odds. And those numbers will only grow higher and higher. I mean, it's almost a no-brainer. The sad part of this whole situation, excuse me, is that there are not enough physicians in the country who are trained in adult congenital heart disease. And if you look at the national data, we roughly have about 70 or 75 trained or so-called trained physicians in adult congenital heart disease. So if you take all of the United States, you're hovering around 75 patients who are trained to do adult congenital heart disease. Most practices have 75 cardiologists. There are 75 trained adult congenital docs in the country. At Montefiore, I'm the only one who does adult congenital heart disease. In New York, we only have 2 programs. There are growing programs in the city now that are trying to develop adult congenital programs, but there's really Presbyterian and there's us that really have a robust infrastructure to do adult congenital heart disease. There's some fantastic programs. I trained at Ohio State and Nationwide Children's in Columbus, and it was a fantastic experience. It's a wonderful program, but there are several programs in the country. What happens with adult congenital heart disease is that it's never a one-man show. You can bring the right person in, but it is a field that has so many arms that come out of it. And we just talked about pregnancy. Think about pulmonary hypertension, which is another arm of it. There is imaging. You need the right MRIs and CTs and echoes. You need a cath doc who can put a catheter in there and sort out what's needed. You need a good surgeon. You need a good ICU team. So it's really an amalgam that comes together. It's a fascinating field. I mean, the fellows who come and rotate through, they sometimes go home thinking, God, I mean, every patient was different.